Okay, so we'll begin. Thank you everyone for coming to our Congenital Glaucoma Brunch today. It's a beautiful day. So I am Natasha, I'll be your host for the day. I am working at Glaucoma Australia as a senior orthoptist. With me today from Glaucoma Australia we have Loretto, who is also an orthoptist, and the beautiful Betty, who you are familiar with, who is the fundraising manager at Glaucoma Australia. We also have Kelly, who is our Glaucoma Australia ambassador, and who will be a speaker as well today. We have Khan Nguyen, who is a pharmacist and sits on our glaucoma board. So she will be flying the flag for our board today. Along with everybody else, we have our speakers, Dr. Mark Chiang, Janet and her guide dog Jasmine, Karen, Cara and Kelly. So thank you all for participating in our glaucoma brunch today. Some housekeeping rules. So if you go up the stairs, then down the stairs, and near the choo-choo train, there are toilets are located on that side. Otherwise, you can go through the gift shop and near the cafe. I believe that there are other toilets as well. Yeah. You're more than welcome to explore Currumbin Wildlife Sanctuary today. I believe Betty has sent out a code word in the email that you can purchase tickets at discounted rates. So you just have to purchase it today and activate it in order to be able to use it on any other day as well. If you can't make it today. I believe that the Wildlife Sanctuary shuts at 4 o'clock today. So if we don't make it today, you're more than welcome to use it another day. Okay, so we'll give a shout out to the country. So Glaucoma Australia respect and honour Aboriginal and Torres Strait Islander elders past, present and future. I believe that we're here today on the traditional land of Yagambie, or the sunny Gold Coast as they call it. So I would like to extend a very warm welcome to you all again. We acknowledge the stories, traditions and living cultures of Aboriginal and Torres Strait Islander people on this land and commit to building a brighter future together. Today's event has been sponsored by AbbVie, so we'd like to give them a shout out and a big thank you for sponsoring us and for their generosity. So thank you, AbbVie. So this is our agenda for today. Obviously we're a little bit late to start, but we just wanted everyone to be here and be able to hear the speakers, so apologies for that. So I will be giving you a brief introduction, followed by Dr. Mark Cheng, who's our paediatric ophthalmologist, who will be speaking straight after me. I would like to also inform you that we will be live streaming to New Zealand and our Facebook members who are not able to attend today. Therefore, I'd like to give a warm welcome and kia ora to our New Zealand colleagues and our and their glaucoma community as well. So I'm not sure if you know about our site-wise program. Being a part of the Congenital Glaucoma Facebook private group, we understand that you guys speak amongst each other and are part of the group. But I'm not sure if you're familiar with our site-wise program. So Glaucoma Australia has a site-wise program where we provide one-on-one emotional and practical support to our patients that is delivered by our qualified orthoptic educators and health counsellors that help patients manage the anxiety of receiving glaucoma diagnosis and supports them throughout their journey and challenges with having glaucoma. We provide education and support, treatment options and compliance, as well as appointment adherence to our community. Our phone number is 1-800-500-880. At any time you call, you're able to speak to one of three of the orthoptists that will be able to assist you. We also have a glaucoma shop where we provide low vision aids, eye dispensers, Frio wallets. Frio wallets are used when travelling around the world or anywhere where there are no fridges, so that your glaucoma drops can be kept at a safe temperature. So what is an orthoptist? Orthoptist is a qualified allied health professional who has a broad knowledge of glaucoma and other eye conditions. So like I said, if you ever call the 1-800 number 500 or 880, you're able to speak to one of the qualified orthoptists that will be able to assist you with your queries in regards to your glaucoma. So these are the 3 orthoptists. So Loretto, who is here, myself, and the other person who wasn't able to make it is Val, and you're able to also call us on our mobiles once you reach us through the 1-800-500-880. So we're part of the site-wise program and we'll be able to support you. So let me introduce you to our first speaker. Our first speaker is Dr. Mark Chiang. Thank you very much for attending today. He completed his Bachelor of Medicine and Surgery degree in Queensland in 2000, followed by a Masters of Philosophy in 2007. Prior to his ophthalmology training, he has spent 2 years as a glaucoma research fellow at the Birmingham and Midland Eye Centre in the UK, and also served as a medical officer in rural Queensland. He then undertook his ophthalmology training in Queensland and completed a vitreoretinal fellowship at the Royal Brisbane and Women's Hospital in 2012, where he became proficient at both the surgical and medical management of retinal and macular diseases. He was then awarded the Ransco Abbott Medical Optics Scholarship and completed a fellowship in glaucoma and education at the prestigious Moorfields Eye Hospital in London. He trained under the eminent Professor Sir Peng Ko for the management of complex glaucoma in both children and adults, and was involved in the development of the state-of-the-art glaucoma draining devices at the Institute of Ophthalmology and University College of London. Dr. Chiang's particular specialties include pediatric and adult glaucoma, complex cataract surgery techniques, including those requiring vitreoretinal approaches, as well as both medical and surgical management of retinal and macular diseases such as age-related macular degeneration and diabetic retinopathy. He has presented at local, national and international meetings and is an author of many ophthalmology journal publications and book chapters. He is a member of the Childhood Glaucoma Research Network to promote advances in the care of childhood glaucoma globally. He is also a member of the International Lindbergh Society, where he is actively involved in the research of pseudoexfoliation syndrome and glaucoma. Please join me in welcoming Dr. Mark Chiang to the podium, who will be speaking about congenital glaucoma and treatment options. So I'll give you, you can come around this way. Thank you. So I will just get Loretto to pop your presentation up.
Yep, do that.
Unless you want to add yours into here as well. I'm just using it as a guide.
Oh, okay. Yeah, let me copy the date. Ignore the file names. Copy, You can probably run it on the USB stick.
It's just a smooth.
Oh, yeah, okay. Might be.
Sorry, I should have tried that before.
So I'm getting on. Okay. Good. And this is linked.
Yeah, and you just use it to.
This YouTube. Okay.
Yeah.
Cool. All right. Well, thank you, Natasha, for the long and very kind introduction. I'm very honored to be here, to be invited to this very special event where we can interact and we can share a very good time in this nice weather in sunny Gold Coast. Okay. My hands full now. Okay. And so please feel free to put your hands up like this. Okay. Hands up, and if you have any questions, don't feel bad if you are interrupting anything. And Now, I've got this book on the table there, and this is done a consensus book, and it's pretty much like a Bible, certainly to me, about childhood glaucoma. And it is a meeting that's a World Glaucoma meeting that's held every 2 years. And I was very fortunate to co-author the surgery chapter. So it's done over 10 years ago. It might be time for an update, but what have we done during that time? Mostly still true. Okay. So before you go on, can I just have a show of hands on if you can think back to what events led you to be suspicious of childhood glaucoma? Let's say, did anybody of you got diagnosed because the pressure was high? No, one. Okay, but it's very rare. What about if the eye was big? Yeah. What about if the eye's cloudy? Okay, so this is something very different, childhood glaucoma compared to adults. In adults, you go to the optometrist to have your regular eye check, and you're told your nerve looks a bit funny, your pressure might be high. But in childhood glaucoma, it's quite different because the child can't tell you what the pressure is, and they can't sometimes tell you if their eye is sore or something like that. So if you look at the definition, other than the three, is there a point? No, don't worry. Other than the pressure and the damage to the nerve and perhaps the visual field defect, to diagnose a child glaucoma is really based on what you observe. And that's very critical in terms of, if you delay the diagnosis, and that could have a lifelong impact on the patient or the kid in this case. And so some of the stuff we see is big eyes, cloudy eyes, watery eyes. They can be light sensitive and things like that. Okay, they can also the eye can stretch, and because of that, they become more and more short-sighted. That is one of the parameters that we can use to tell whether the glaucoma is well under control. Again, show of hands if you know what type of glaucoma that you or your child might have. Okay. Show of hands if you got primary congenital glaucoma. Okay. What about, say, uveitis or anything like a syndrome? How many of you have had glaucoma develop after cataract surgery? No? Okay. Anyway, childhood glaucoma, similar to adults, it can be subdivided into many different types. So there are primary type and secondary type. And probably for the purpose here, we will concentrate on the primary congenital glaucoma. But in the clinic, we also see a bulk of glaucoma from other causes, such as, after congenital cataract extraction, they can get glaucoma. Sometimes they can have syndromes that they have systemically that can be associated with glaucoma. So just like I mentioned before, it's quite different in terms of the presentation in childhood glaucoma compared to adults. The age of onset is quite important because the later the onset, it is said to carry the worse prognosis. Some kids will have watery eyes, photophobia, and their cornea can be hazy. What's important to know is that the kid, I actually need two hands for this, but the kid, just like a lot of the young ones here, when you pull their skin, they're very, very elastic, very cute when you pull them. Same with the eyes, because the collagen fibers, when they're young, we think it's before 3, it's not quite strong. So what happens is the pressure can stretch the eye, and that will make the eye big. And because of that, they can split like that out there in the front of the eye. And we think it's that splitting that causes the light sensitivity. And certainly with these changes, that can make management challenging. And I'll show you why as the talk goes on. Okay. So what else is different? Well, as opposed to adult glaucoma, where a lot of the time the patient just sees one specialist, for example, a glaucoma specialist that sort of manage their glaucoma. But for a child, for a kid, it's very different. One, the kid's not going to stay there and let you do what you want to do to them, okay? And for maybe some of the older patients, you'll remember how many times you had to go to theater because the specialist could not see or could not examine the kid as good as they wanted. So sometimes you have no option but to take the children to theater just to have a look, okay? And this is my boss, Professor Sir Penko, one of his old pictures, and that's what we need to do quite often. And almost opposite to the adult glaucoma, childhood glaucoma is almost regarded as a surgical disease. So surgery is almost inevitable, and eye drops only forms a small part of the management. Also at the same time, very, very commonly or frequently that the kid might have a lazy eye or they may have a squint. That all needs to be managed concurrently to ensure proper development of the connection from the eye to the brain. And the last thing, which is a lot of the time the medical people tend to ignore, is the supportive network, okay? And so, for example, what we're here for, Glaucoma Australia and the online support groups, and it's been shown on the literature that the parents, the caregivers, is really what makes or break the management for childhood glaucoma. There's no point if I do a very good surgery and I can't see the patient again. So that can happen. So medication is one of the options for the treatment of childhood glaucoma. But as opposed to the adult world, where that is the mainstay of treatment, where a small proportion needs surgery, drops in kids are usually to buy you time before you do surgery. Or perhaps you've already had surgery and it's like a supportive therapy just to bring that pressure down to the level you want. There are different types of drops, obviously, and I'll try to not to talk too much about them. But just to let you know, drops is not the mainstay of treatment for most cases. So why is it challenging for us? You'll find that in Australia, there's probably one or two ophthalmologists that deal with, one or two per state that deals with childhood glaucoma. And that's partly because it's very challenging, can be very stressful for the surgeon, and you need a lot of training for this. So just like I mentioned before, the eye can get stretched, and because of that, the eye becomes big, becomes very elastic. So if you think of a big eye stick into a small head, small eye socket, that can make surgery very challenging. And certainly what can happen is that the way the eye responds or recover to surgery can be somewhat unpredictable. And if something goes wrong, it can go really wrong if your surgery is not done well. And just like I mentioned before, there's a very big lack of cooperation, and so you've got to be able to judge whether you can see the patient afterwards, what the supportive network is like. Again, just show of hands, who has had angle surgery, for example, or goniotomy, trabeculotomy? See, a lot of you would have had it. Trabeculectomy, yeah. Tubes, yeah. And some of you may have had all of them. So that would just depends on the type of glaucoma you end up having. And so just to carry on into the common surgical options, there's the angle surgery, and I'll try to explain this in a simple term. Just imagine this is a room filled with water, that's your eye. Your natural drain would be like the skirting board. So what happens is, in the primary congenital glaucoma, it is thought that these drains have not developed properly. So the idea of angle surgery is to somehow open up this channel And so you can do that from within, or if you can see it from the outside, do it from the outside. And that's the idea of angle surgery. And then there's trabeculectomy. Some of you would have had that. But that is much, much less performed now because how strong the kid can heal. It is more common to do glaucoma tubes now, and because it is a much more robust option in terms of surgery, and it is also longer lasting. Laser treatment. How many of you have had laser treatment? Yeah, so some of you may have had it, and it can be used as an adjunct to surgery, or again to buy some time. So what goes into, and I apologize for the not so pleasing pictures. That's the more pleasant ones I picked. What goes into my head when we pick what operation? Certainly, you've got to go in with the mindset of that the first chance is your best chance. Certainly the intention needs to be there, even though some of you may have had 2, 3, 4, 5 surgeries. Okay. The type of glaucoma is important. There are some surgeries that can be done only if the cornea is clear. Okay, so for example, think of the cornea like the ceiling. If you want to cut the drain, you've got to be able to see through. So goniotomy cannot really be done if the cornea is totally cloudy. So in those cases, you need to go from the outside. The conjunctiva or the state of the tissue, for example, that bottom one there, that's not very good if you want to put, say, a tube or trabeculectomy. That's a no-go. Okay. But at the end of the day, it really depends on your specialist and your surgeon. And it's very dependent on what their training had been. And I'll show you later on in a survey just to see how much variety there is to control a patient's pressure. So just a quick kind of go through on angle surgery, because angle surgery is actually the workhorse of primary congenital glaucoma. And if it's done right, that could be the only operation that someone might need in their life. So it came from the 1940s, but it's slowly improved over time or modified over time, depending on where you are and what your training had been. Oh, this won't play. Can this play? So you can see this cornea is a little bit hazy. So I can just press play there. Yeah. Maybe it doesn't. Okay. No, it's not playing. It's all right. But if the cornea is totally cloudy, there's no way I can see to the other end. It's all right. It's okay. It's okay.
Technical support.
It's all right, we can play later. It's fine, we'll skip this. But this is just shows some of the approaches we used to do angle surgery. Okay. And trabeculectomy, like I said, is less and less commonly done, because in the olden days, people don't use anti-scarring agents, and so the success is very, very low. But even with what we call mitomycin, which is very strong anti-scarring medicine, the success is not the greatest. And that's purely because, one, the kid heals very strongly, and two, after this kind of surgery, there's a lot of theater time required, and that's not always possible. Depends on where you are. And also, not to forget that we have a live patient in front of me, and we're interrupting their life by taking them to theater all the time. The glaucoma tube, which some of you may have had, there are different models and sizes, but this is really the workhorse of childhood glaucoma, It's not just primary congenital glaucoma. And this is the operation that is tend to last the longest and that can stand further operation in life. And certainly sometimes I get overseas fellows that come to the children's hospital. They might stay for 6 months or something. And I said to them, if you want to deal with childhood glaucoma, if you don't have time, you just learn this operation and that will get you through. That's not necessarily the best option for all cases, but the tube surgery will get most people through. And when everything else fails, you can do lasers, and there might be newer therapies, but I will show you why sometimes these new therapies may not be the best option. So this is a survey I did back 10 years ago for that same conference, just surveying the worldwide specialists that deals with congenital glaucoma or childhood glaucoma. It's about 80 of them, but there's probably more, but these are the bigger, well-known people. And just one of the page as an extract from it, there's just a map of the extent we surveyed. So this is for primary congenital glaucoma. And the question here is, what's your operation of choice if you have primary congenital, if you see someone with congenital glaucoma? And you can see there's such a wide spread. Some of them will do goniotomy, some of them will do tubes, some of them will do the same angle surgery from outside. So what we've got from this survey is that there's no right or wrong. It's whatever works for the patient, whatever works in the surgeon's hand, okay? And so sometimes you might see different specialists, they may say different things. That does not mean one's right, one's wrong. These slides, generally, if I give a medical talk, people don't like to see this. But I think in this context, this is very important. Okay, so I'll just go through the questions, which I can't really see. But I think the first one means, is primary childhood glaucoma surgery more risky? Carries more complication? And certainly, the answer is overwhelmingly yes. And also, might just come here actually. And can the surgery be improved by meticulous surgical technique? Over 95% of the patients said yes. So that also reflects on how much training is required. If you're not trained, don't do it. Okay. And the third one is, do we need better glaucoma drainage tubes? Over 90% says yes, we need something better. And the next question, very important, do we need more research? 100%. The last one, which is not too much of a surprise to me, but it may be disappointing sometimes to the patient, is that do you do some of the newer procedures such as stents or some other devices for people with childhood glaucoma? And almost 90% says no. Okay, and the reason for that is not because we're conservative or we're not innovative, because we don't want to put a child through something that's untested, that's not well known, is it going to work, and put them through more general anesthetic. And so quite often I'll get asked by optometrists, oh, I've got this patient, can you put a stent in this 10-year-old? And sometimes you don't want to be rude, but you just think, well, it's not going to work. Okay, so you've got to keep that in mind. Sometimes the latest is not always the best. Just to recap, I will skip this pretty quickly. Primary congenital glaucoma, we tend to stick with angle surgery. And when I was in the UK, I actually saw one of the first one that was ever done. He was already 80-something or 90. He just had the one operation when he was a baby, and that was it. So very, very important surgery. Secondary glaucoma will tend to skip, but angle surgery tend not to work well here, and you tend to be looking at trabeculectomy and tubes. Now, can we get that? There's a video.
There's another video?
Yes, yeah. This one is better if we show it.
Okay, yeah. Sure.
I'm going to try to see if I can run this next video. And it is about Oscar, who is actually one of my first patients in childhood glaucoma when I came back to Australia. It's done in an event a few years ago at Queensland Eye Institute, and it really highlights some of the journey that he had to go through, some of the difficulty he had to go through, and Melissa and the family had to go through in part of the journey.
Oscar was the fourth child. At 6 months, I noticed one of his eyes appeared slightly larger than the other. I went to the GP and she referred us to an ophthalmologist. He looked at him and said, I think he's got congenital glaucoma. He went to surgery 2 days later for a major operation, but unfortunately when he was 3.5, I noticed that his eye was looking rather large again. The pressure had skyrocketed in his eye and he required more surgery, a more complex surgery than had been done 2 times previously.
When I was getting the gas, I just wanted to say stop, and they just did it, and I just hated it.
What do you call it when you go to theatre? It's called, you're going to?
Dr. Buzz Lightyear.
So for some reason he's associated the anaesthetist and all his machines and theatre as Buzz Lightyear's ship. And to this day, even though he's 9, we'll be driving to Brisbane for an eye appointment and he'll say, am I going to Dr. Buzz Lightyear? And you can hear the fear in his voice that he's going to theatre.
Ran to the sand and then just went in the water and
Rode a boogie board?
rode my boogie board.
We'd been at Queensland Eye Institute in the morning and got the go-ahead that we could swim, and it was a stinking hot December day. So we drove back from Brisbane to the Gold Coast, called in at home, put the rashies on, the boardies, and headed to Main Beach for a swim, and Oscar was euphoric to be able to go to the beach for the first time, and the joy that he felt and radiated from the minute we hit the sand. He raced down, felt the sand underneath his feet.
I've never felt the sand back then.
How did you feel that day, Oscar?
Joyful. It was the best time of my life back then.
Yeah, so this just highlights sometimes as doctors we just keep doing what we do, and we really don't really know what kind of impact we've had on the patients in their lives. And certainly I can't remember at what age Oscar told me one thing. On one of the consultations he told me that you are interrupting my education. And that's stuck in my head ever since. But I look at him, he's doing well, okay? And so that will be the end of my talk. Thank you.
Thank you very much, Dr. Cheng. Any questions for Dr. Cheng? Whatever you may think, or
Yes.
if you don't feel comfortable asking
Anything?
right now, feel free.
Yes?
What are the likelihoods of Oscar passing on his congenital glaucoma to any children?
That would depend on the gene he's carried.
Okay.
So at this moment we haven't done genetic testing. So
Can genetic testing be done?
yes,
on him?
yes, yes. So that can be done, and that would depend on what kind of gene we found.
Yep.
And if some of that's been found, then that would depend on the inheritance pattern. Then you can work out the percentage or the likelihood of passing that on.
Okay. And
Yeah.
then say he was going to pass it on.
Yes.
The IVF technology in Australia developed enough that they could say, okay, that embryo carries that gene, and we don't want to pass it on.
I think in the future, maybe. Not at the moment. I don't think the technology is good enough to be that finely, that specific. Yes. There's several places. One of it was the one in Adelaide. There's a registry of advanced glaucoma. They also do a lot of kids testing. That's in Adelaide, I think South Australia, at the university there, under Professor Jamie Craig. He's also got a commercial branch that can test, I can't remember the name, that costs a few $100s to do a full genetic profile. And it sort of gives you a risk profile and what's the likelihood of this person getting this type of glaucoma or that type of glaucoma. I think there's one in Brisbane. They collaborated on that project. There's one at the QIMR near the Royal Brisbane. But I don't know how to enroll in that one. But there's quite a few different ones. Yeah, but the main one, if you want to, say, get it for less cost or for free, then that's the Adelaide one you approach. Yeah. Sorry? WA in Perth, there's the Lions Eye Institute. I don't think they run any service like that. But the one in South Australia, yeah, so it can just done by post. Yeah, you don't have to physically be in that state. Yeah.
I'll send an email afterwards with the details.
That's it.
That's good.
Thank you very
Thank you very much. Oh,
How old's your oldest CG patient?
sorry?
How old is your oldest CG?
My oldest, I think, probably not that much here. You'll be like 70 or 80 year old. Yeah. So, yeah, NCs, yes. So you probably wonder how good they are. It really depends on. There's no reason why a CG patient can't go on have a normal and successful life. Yeah, exactly. There you go. Yeah.
Yes, sure. Thank you. Thank you very much. That
Thank
was
you.
very good and very informative. So I'll introduce the next speaker. So our next speaker is Dr. Sau Kuan Cheong. She's a client services manager at Guide Dogs Queensland. She obtained a bachelor in psychology and her master's in clinical psychology at the National University of Malaysia. She graduated with her PhD from the Australian Catholic University, and her doctoral research investigated the self-concept of pre-adolescent children and cerebral palsy. Currently, she practices as a clinical psychologist at Guide Dogs Queensland, where her clinical work focuses on individuals with vision impairment and their families. Her role supports clients and their families throughout different periods of adjustment at varying degrees of vision impairment. Through this process, many individuals with vision impairment adjust to changes in their lives following the diagnosis of vision impairment and create a fulfilling life. In her management role at Guide Dogs Queensland, she oversees a team that consists of orientation and mobility specialists, occupational therapists, assistive technology specialists, and psychologists. The team delivers services across Queensland to support individuals with vision impairment and their families. Please join me in welcoming Janet to the podium, as well as a beautiful dog, Jasmine, who is attending with her today. So perhaps if you just come around here. So you'll have your hands up. Yes.
Thank you. Very happy to be here today. Set myself up. So what I wanted to kind of have a little chat about today is what does it really mean having a vision impairment, because it's more than just losing your ability to see. It's the impact of vision impairment ripples across our life in a much more significant manner. And I do have to kind of say ahead of time that the presentation today is structure a little bit more in the sense of children and families. But I'm happy to have a chat if you have any other questions in relevance to, you know, what does it look like for an adult. So at Guide Dogs, we call it a journey of vision impairment, because often we notice is that it's not just the one point. It's not that point of diagnosis, as you've heard from Dr. Chiang's presentation. It's continuous. It's so, with the children, we have had undergo so many different surgeries, and along that way, we see what we do with our clients as a journey. We journey alongside them. They come in, they go out. They come in, they go out. We walk alongside them with whatever that they need at that point in time. Doesn't mean that the minute they come in, they need everything. It's tailored to what is appropriate at what time for the best interest of the client. Now, so what does it really mean, having a vision impairment? What does that diagnosis mean? Often we talk about it being the primary impact, which is the loss of vision. So when often I talked to the general population, the general public, they always have this impression that it is a black or white. You can see or you can't see. But we all know vision impairment actually lies more in the gray zone. The number of clients that I have in the gray zone is so much larger. The ones who can see some, can't see all, can see some in some areas but not in others. And every single one of them are different. And hence why it's so important to be able to have that conversation with the clients being, what is important for you? What is important for you and your family? Now, so after we acknowledge, yep, what does that look like? What is the residual vision? What does it mean? What does that impact is? We often also forget that the primary impact is just the starting point, because often the secondary impact is way greater than the primary impact, and often the secondary impact is not something that we pay attention to, because we're so focused on what can we do to get to maintain the residual side, what can we do to make things better, right? But along the journey, as you have your consultations with your pediatric ophthalmologist and all your other practitioners, clinicians, your medical team caring for yourself and your child, but we have to remember, like what the little child was saying just now, Oscar, isn't that right? Doctor, you are interrupting my education. Yeah, because we have to consider that the secondary impact is all those other things. Physical development, social development, what does that mean for the child? So you imagine, how frequently have you seen a parent taking up a toy? Usually it's a soft toy. Sorry, today my back is not big enough, can't get the soft toy. Wave the soft toy, and the child gets attracted to the soft toy and will aim to grab the toy. But what if the child can't see it? You've lost that ability. How many times have you seen the parent waving the soft toy and the child takes their very first step? That is physical development, moving towards something because there's a motivation for it. But if you have lost that visual cue, you wouldn't move towards it. So you need to have other ways. Of course, we all do. Find a rattle, right? Great alternative. There's always alternative. But I've also seen a parent, a little child with the parent, and the parent waved a rattle. And what the child did was that the child was sitting on the ground, and the child opened his palms, and he just went open, close, open, close, open, close, open, close, open, and she waited. And guess what? The toy magically appears in her hands. So she realized that, oh, actually, that's what I do, because that's what the feedback was from the school, was that she wasn't going to explore and to find things. So that was my task. How do I get her moving towards the toy and not just sit there and wait for the toy to magically appear in her hands? So after a little while of interaction with the child, a couple of sessions of therapy with the child and the parent, the child was exploring the school, and the teachers were amazed. She discovered things didn't need to move. And that was the next bit I had to tell the teachers, that now you have to keep the things put where you put them and not just magically move them because you can't find them after. So all those different things, so many of our everyday requires visual cues to learn. You learn from other people about social interaction. What do you do, what you can do, what you can't do. All those require social cues to learn. So these are some of the impacts when we have reduced social cues. So these are the things that we need to take into consideration and create alternatives to ensure that the impact is not as massive. Now, when we talk about vision loss, we often talk about the symptoms of grief and loss. So for someone with a vision loss later in their life, this is often the slide that I would use. We talk about the initial point of diagnosis, really traumatic up and down, and then the person begins to kind of drop or fall down into a bit of a rabbit hole because they begin to experience the different losses because of the loss of vision. But as I always say, life doesn't need to look like this. It doesn't need to end with lots of hopes and dreams, because if you obtain the right supports and services at the right time, it can change that trajectory. And you can live a fulfilling life. I have many clients who live a fulfilling life doing what they enjoy doing. Some of them might be working full-time still. Some of them work part-time, volunteer the other full-time, or work part-time and have leisure the rest of the time. Because it is important to ensure that you have a balance in life to live the fulfilling life. However, this chart doesn't quite always make sense when it comes to children, because the symptoms of grief and loss are actually experienced by the parents more so than the child, right? So in parents, this is sort of like the trajectory that I've observed. At the initial point of diagnosis, a bit of a confusion, uncertainty, ambiguity, going in and out of doctor appointments, surgery. Is it one surgery? Don't know. Could it be 5? Could it be 18? Don't know. A lot of uncertainty. And then I see if the if the grief continues, there's often a sense of self-blame that I gave this to my child because the child didn't have the choice to choose sometimes. Is that what they feel? But it doesn't have to be that. But this is the thinking process that often happens that I observe in some clients. And then if that continues, I also see parents begin to disengage from the parental role, disengage further from their child. They continue perhaps to send the child to therapy, but they might not necessarily engage. And eventually, loss of hope for their child or their family. This is where Dr. Chiang was saying about the parent is the point of breaking loose. Whether you would achieve what you want for the family, not just for your child, because the trajectory can be very different. If we are able to provide the family and the parents with the right supports at the crucial junction, and often it's at the very beginning, we begin to see an acknowledgement of those grief. It is okay, it is normal. It is part of that emotion because you're going through a really, really unexpected experience. No one would wish for something like that. It's not something you would expect whatsoever. But it is what had occurred, and if we acknowledge, what happens then is that you begin to accept, well, We can make a life, we can make a journey. Journey might be slightly differently, not what you might have anticipated it to be. And you begin to engage in a collaborative network, support network to focus on the child's development. And with that process, then you begin to adjust your life, adjust your perspective of life, creating future with and for your child and your family. So you're creating that future with them. Right? Now, what kind of supports are we talking about, and what kind of impact do we see if we do that? Often, at the very, very beginning, at the early stages, early identification is crucial. The earlier we are able to identify, and the earlier the referral, which means that the parents and the family are getting that support. So psychological support is something that will be able to support the family unit through understanding what this symptoms of grief actually means, understanding what this change actually means. What does this journey actually look like? But more importantly, it is crucial to have the medical support, so medical specialists to provide the right information that parents understand. Like Dr. Chiang's presentation just now, is not just all jargon. So many times clients have presented in front of my consult room and they go, I have no clue, the doctor said blah, 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 blah. And they gave me a whole report of all the jargons that the child might be presented with. That cannot help the parents make informed decision. So if you are one of those, I urge you to ask and to get the right information, the right supports to make sure that you understand what is it that is crucial for you. Because that knowledge is the key for you to get to the next bit. Once you understand what that looks like, then you're more engaged. You know what to expect. You're more engaged with what your child needs. And these are the points when I see the parents are involved in the sessions with the child. Because as I often say, especially when it comes to speech therapists usually you have an hour consult a week or maybe even a fortnight. The child don't learn to speak in that 1 hour that they see the speech therapist. It's all the times in between that creates that practice, that understanding, and that's where the speech grows. Same goes with all of the other practitioners, same with all of the other services. You need to be able to know what's happening, to be able to then do all of those things in the session and out at home. So I always say, at the end of the session, I'll give my parents homework. Sometimes it comes with a homework sheet in case they forget. Absolutely. But the homework needs to be fun. The homework needs to be doable, not yet another chore or another homework for the child sitting in the textbook. Right? So it is working collaboratively with your support, your service support network to make that happen for you. We see that if we are able to achieve this at early stages, before they get into school, they stand a much better chance of getting into school more or less on par with their peers. And that's important, because once they get into school, then the collaboration changes slightly. It's a collaborative service between the school, during school and outside school. During schools, there's actually a lot of services for children with vision impairment, so make sure that if you are in any of the Queensland education system, to connect with the school to find out what are the services available for the school. So at Guide Dogs, for example, we do go and visit children at school to do some of those skills as well. But we also do it outside of school, depending on what's required. So if you have that combination, it reduces that stress on the child that you have to attend yet another thing after school. It reduces that impact of stress for the family. I can just imagine how many consultations that you run into, appointments after appointments after appointments, right? So we don't want for our appointments to interrupt the child's education, because it is crucial for them to be able to live the life they want. And it's not just about the education, they want to come home and play, right? So creating that sense of family, supporting the family through this process. Now, so when we talk about the family then, it is about an inclusive family. How do we do inclusive family fun? Right? What are the kinds of things that we can play with that is inclusive for the entire family? So, and this is crucial because when we think about the child and the family unit, sometimes, and many of the times, you're not just thinking about one child. You have to consider you might have more than one child. And siblings are as important. Every single child is important. But because when they have a health condition, a vision condition, it takes up a stronger proportion of time away from, that takes up the proportion of a family's time away from the other children. So we have to remember to have that balance as well. What kind of fun can we do? Now, if those of you who are here today, I actually have some of these things that I'm going to be talking about. So happy for you to have a little look and explore. Now, the first thing often we think about in terms of, okay, games, right? We need to go to specialized shop, do specialized equipment. Maybe it is the, things with braille. If they need braille, often it might not necessarily be, but it could be things with large prints, or I go to Queensland Blind Association, I can get all these adapted things, got things with high contrast so that you can play. But they are all specialized equipment, right? You don't necessarily need them. What we would like is for game companies to open their mind, to expand, to create things that are already adapted. So I was very excited to find that Hot Wheels has braille on it. That's pretty good. Rubik's Cube in the brand in itself, so you can get these things in like Toy World, for example. It has tactile. So it doesn't matter whether you have a vision impairment or you don't have a vision impairment. The tactile is just an added feature to the toy. It doesn't have to be going to a specialized shop to get something that works for them. Othello. It annoys me every time because Othello often it is a magnet, and if I lose the pieces, I lose the game. However, I've discovered this Othello version. Even though it says it's for no loose pieces, but it has features that absolutely works for many of our clients because it provides tactile features. The squares are raised, so it's got some guidelines, guidance, and each of the markers flips over to create the black or the white. So you don't need to go hunting for your markers. And one of the additional things that I did was on each of the white marker, I put a like a little sticker on top of it, just so that it gives it the extra tactile feature if the contrast is not sufficient. So simple things like that is available out there that we could easily adapt these things. But more importantly, I want us to be able to expand even further. Vision is only one of 5 senses, but look around us. How many of the things that we have are visually driven? And that is not human in its nature. It is human in its development. When you think about us many, many generations back, your vision is not your primary sense. You use a lot when you are hunting, when you are a hunter and gatherer, you use a lot of other senses. But we have sense over development over the progression of human development. We have zoomed into using vision. Vision has become the primary sense. But it doesn't have to be the only senses, right? So I would like, for more and more games to include all the other senses. So Boppet is one of my all-time favorites. I have all of the different ones, from the big one to the medium one to the mini one as well. It's very much a audio game, so you don't win even if you have great vision. It's all about audio, and each of the console area where you're supposed to manipulate are well defined and different enough to be able to differentiate them. So introducing games like that pull the playing field fair across the entire family and the friendship group, right? There's also many other things that we can introduce if we put on our creative hat. Now, being creative around our games and family activities, having music trivia, for example, reading sandpit, very tactile. Bird watching, a couple of years back, I decided, you know what, I have some time, I'm going to learn how to do bird watching. Guess what? I've learned very quickly that bird watching wasn't watching at all. Yes, they are so good at camouflaging. And I've got a client who is amazing with her ears. She just sits at her front lawn and she can tell me around her surrounding, there's this, and this bird. I'm like, where? And she will point to me in that direction and I still can't see it. So there are things that utilizes our other senses, but we're not always taking advantage of them, because in our surrounding, the vision tend to be one of the primary senses being used. I think I missed one in the slide before. In Apple Store, there's actually a whole series of blindfold games. They're actually auditory games. So even if you're sighted, it doesn't help you in whatsoever way. Played them, absolutely fun, but these are some of the things that you can introduce in the family that allows for all of the other senses to be utilized. I once had a client who was a school teacher, she's like one of those kindy teacher, and she's an assistant teacher. And as her vision deteriorated, she began to ask, I'm no help to the children. I'll probably not be able to do this anymore with the children. And I told her, you're actually in a really, really good position, because most of the time, teachers or us in general tend to focus on what we can see. What are the visual cues? What are the things that are visual? I say, you have the position to be able to introduce the other senses to the children, and to introduce games and things that taps the other senses in addition to vision. And a couple of weeks later, when I saw her, she was absolutely thrilled, because she did all these different games with her kids, and the kids were doing them with their friends. So they were not just all running about crazy trying to chase each other, because they're doing something else. So having to think about how we can create activities, everyday things that includes the entire family, because that's how we can bring the family together. Thank you. Any questions?
a comment. I totally echo what Janet said. I used to run the glaucoma support group or think tank in the UK, and I ran a few sessions for childhood glaucoma. And what you found that the session is really for the parents. So what you found that the kids are running outside having a great time, and it's the parents that's sitting there, some of them crying, some of them grieving, and so on. And so that's totally true. And the other thing, is that I think it's the loss. If you lost something, that's when you need to adjust. I've got patients who was born with very little vision, and that's all they've had, so they adapt. So the kids just do just fine, and they just carry on with life.
Yep.
And that's how resilient they are.
Yeah. Because vision is one of 5 senses.
Exactly.
I often tell my client, it's really us, the sighted people, who are not maximizing our resources. When I came into this role, I learned so much more, and I learned to use my other senses better. I've learned to eat with my sense of taste and smell, not necessarily my eyes anymore. Yeah. So all the different kinds of things that you can encourage your child and make that shift for your child, because you give them the power, you empower them to do so and guiding them to do so. So I do have some of these toys with me. If you're interested, during lunch, happy for you to come and have a look, come and have a play. I do have Jasmine with me as well. If you would like to take a picture during lunch, happy to do so. Any other questions? Oh, good. Thank you. Thank you, Janet. And thank you, Jonah.
Can I just say, I love Janet's passion and lateral thinking, and she's very contagious, so her energy is very contagious, so thank you. And just like Dr. Mark Chiang, Janet has a niche market. There are a lot of psychologists available in Australia, but not many that know what patients with vision loss experience and how to deal with it, and their families. So I think it's a little niche market that you really do benefit from having assistance from Janet and Dr. Mark as well. Okay. So that brings us to the next speakers. We have Karen and Cara, who are both paediatric occupational therapists working for Vision Australia. Cara graduated from the University of Queensland in 2022 and has been working with Vision Australia since March this year. Karen has been an OT for many years and has been working with Vision Australia since 2017. Their role as paediatric occupational therapists sees them working with clients in a variety of settings, helping children achieve success and setting up families for the best support supporting families to the best support the child with performing the tasks that they want and need to do. Please join me in welcoming Karen and Cara to the podium. This topic today will be an occupational therapist's toolkit for kids with glaucoma. Thank you.
I love public speaking. I'm wrong with that. I'm Karen, this is Cara. We're both OTs from Vision Australia. Anyone know what OT is? Occupational therapy? Some people are nodding. I'll give you a bit of a blurb. Occupational therapy. Occupation isn't about getting you a job, but maybe it is in some different settings. But we use the word occupation more broadly in terms of it being the roles and jobs and bits and pieces you've got to do every day at whatever age you are to get things done. So for our little people, that can be everything across like looking after yourself, brushing your teeth, doing your shoelaces up, age-appropriate chores. That's a loaded term, and that's very much house rules as to what you expect your kid to get up to. And then as they get a little bit older, how they manage going to daycare, school, that sort of thing. So OT uses mainly activity-based stuff to get kids to do the things they need to do. So play-based activities is usually how we get kids to practice the cool stuff they've got to do. So we teach people how to do things. We show them different techniques. We might show them use equipment. We might modify the environment. So depending on what you're working on, You can be doing all sorts of fun things with kids. So we work with children with low vision and blindness. So the stuff I'm going to talk about will be covering probably that more broadly. So we work with kids with glaucoma, but then there's a lot of other eye conditions out there, as you probably know. So basically, the things that guide what we do very much, or the strategies that we're mindful of, is the importance for people with young vision to use the other senses that they have to do the stuff they've got to do, and realising that young people with low vision sometimes get small or fragmented pieces of information around a particular task. So a lot of kids learn just by what they've been exposed to, sort of natural learning experiences. So they just watch and observe mum and dad do stuff around the house. And if you've got issues with your vision, you might be missing a lot of the fine detail around that, which can be problematic to your learning to how to do that task. So you might not be able to rely on your sight alone to acquire all the info you need to do a task. So it then harks back to the importance of our young people having real world experiences, hands-on experiences when they're learning how to do things. And for us as OTs and for parents and teachers and people working with these young people, we need to be mindful that these kids might need specific experiences, hands-on learning, or actually explicit teaching and how to do a particular task. So that then leads on to us having clear expectations and explanations around what we're doing. In a practical sense, I think about my own kids. My kids know how to mop a floor. Quality might be an issue, but I have never, my children have normal vision thankfully, but I have never sat there and explicitly taught them how to do that task. So if they couldn't see how to do that, how would you know how to do it? Where this comes up is we get kids sent off to school camps, so there's often these sort of crisis moments, and they'll come back and they go, a little student comes back, oh, he couldn't, he was rubbish at loading the dishwasher. That comes back. And then when you drill down and you think, well, what experience have they had loading a dishwasher? They don't get to just watch mum and dad do it and by the process of osmosis learn how to do it. There's no reason that child can't learn how to load the dishwasher, but they might need that explicit teaching and experience and hands-on exploration of that task in order to do it. So, it's sort of interesting how things come up in our line of work and how, issues arise. Now, if you've got some spare time, this woman here, Dr. Karen Wolf, she talks a lot about more that big picture stuff and the importance of what guides a lot of our work, which is the expanded core curriculum. I won't go on too much, but she's a very cool lady who's had many, many years of experience as an educator, and she comes up with a lot of those big world sort of concepts about like having these clear expectations, the explicit teaching and stuff like that. And her big areas, she talks about the importance of encouraging socialisation. That's kids practicing how to behave in a social setting and being mindful that a lot of our young people with low vision miss a lot of the non-verbal stuff. And so sometimes that explicit teaching can be things around like behaving and interacting in a particular setting. She talks about the development of compensatory skills, which is like using your other senses. It could be using assistive technology, it's stuff like that. She talks a lot about the importance of us giving realistic feedback to our young people. So, and that's not just like praising lame stuff either. You know what I mean? You can kind of talk people up, oh wow, oh that's fantastic, you did that. If that's an age-appropriate chore and that's an expectation that you get your stuff into your school bag before you walk out the door, we don't need to turn cartwheels. It's a realistic feedback. The flip side of that is we should have high expectations of our young people. We should, wish them all the best. We don't want to bubble wrap people. People should lead full and busy lives, so we should have high expectations. You should do well at school. You should do your homework. If there's PE, why not be part of it? This is the sort of stuff we need to champion for our kids sometimes, because sometimes, as much as Janet mentioned, the fairy godmother effect, things magically appear. Well, that's not conveying high expectations, because when you're in your classroom, you've got to find your pen and get on with it. You should be doing that, shouldn't you? If we suddenly throw the clag at them and it's there, they're not learning the stuff they need to have, the stuff they need to do. And then she talks more generally about promoting opportunities for work. She's talking big picture stuff like the age-appropriate chores and bits and pieces like that. So what we've done leading into that is this is the sort of one-on-one stuff that we do when we've got an activity that we're working on with a young person that they need to be better at, and that could be because mum and dad need them to be better at it, so we get out the door quicker in the morning. Or I work in the school space, so a lot of this stuff is the stuff I feed back to teachers around tweaking the activities they might do in order to make it more user-friendly for someone with low vision. So I will hand over to Cara.
Thank you, Karen.
Thank you.
Okay, so we talk a lot about how to make things more accessible if you're not able to see properly. You can see an example here on the left. That's not really as easy to see as something on the right. So bigger, bolder, brighter is a big concept that we work by, trying to make things a little bit easier to see so that it's not taking up as much demand on your body, because if you can't see very well and you spend all day straining your eyes trying to see something, that's going to lead to fatigue. So we want to try and make things as accessible as possible. So bigger, bolder, brighter is one of the ways we can do that. High contrast. So we brought some little props here as well. And some of these concepts are a little bit similar and overlapping. So Karen here, if you have a look at the green highlighter there against the green paper, it's not quite as easy to see as if it was to be against a black background. So these are practical things that you can think about in your home as well. So I've got a little girl I was working with. She was learning how to use a spoon to feed herself some yogurt. And the first thing I noticed was it was a white table in the house, it was a white bowl, and it had like white yogurt in it. So it's not as easy for the child to see the yogurt, how much yogurt's left in the bowl and the table. So doing something like putting a placemat like this down just helps show where the bowl is, and you probably use a bright coloured bowl, single colour, because the next one is visual clutter. So if you've got a bowl with characters and things on it, it's beautiful to have those sorts of things for your child, but it might mean that they can't see the yogurt as easily or how much they've scooped out of the bowl. So again, using the highlighter as an example there, seeing that highlighter against something that's quite cluttered in the background is a little bit more difficult. So we try to simplify. So if you could use something like that black placemat, I carry that around in my kit to all my families, and if we need to do an activity and there's a bit of visual clutter or the contrast isn't great, I pull this out and start doing the activity on that, just to provide that little bit of contrast to make it a little bit easier. Oops. Organisation and structure. So it would be really nice if we all lived in a house that was perfectly organised and everything was in a place, but that's not reality, right? But for our little kids who might have low vision, it's great to be able to provide them with a place to put their things. So even if the rest of the house is a pigsty, everything's everywhere, if you've got a place for your little person to put their things and they know where to go and get them, that's again reducing that visual fatigue, or they're not forced to then go and look around and try and find it. If they've got a place for things, it just makes things easier. Same goes at daycares and schools as well. So part of the role, we do go into daycares and schools and help find places for kids to put their things, like their bags in a cubby hole. If you've got a whole wall full of cubbies and kids' bags, it might be better to put the child with the low vision's bag on the end, or have a tactile marker or bright coloured marker or a little puff paint, something like that, on the cubby to help the child locate it. Same with shoes and things like that as well, having a place for them at daycare. Radio talk. So this is where you just talk through everything that you're doing. So if you're in the kitchen making dinner, again, it's the fairy godmother effect that we talked about, like something magically coming into the hand. The child, if they don't understand what you're doing to make dinner for them, they will just think that the meal will magically appear in front of them. So if you're in the kitchen making dinner, talk through what you're doing. You know, I'm going to the fridge, I'm taking out the, whatever it is, the carrot, I'm using the peeler. So all of those sorts of things can really help kids to understand the concept of what's going on. And concept development is another really big thing that we talk about a lot as well with kids with blindness and low vision. Just for them to understand all of the things that you're doing if they can't see very well. Hands-on learning. So we talked about this a little bit as well. I think it was covered, but just giving the child an opportunity to do the tasks that you want them to learn how to do, which is most everyday things that you'd expect. So not just doing everything for them, those high expectations that Karen sort of mentioned, giving them the opportunity to learn. They may need a little bit more support or that explicit instruction, but giving them the opportunities to do all of those tasks and practice those tasks will just help them become more independent. And then I touched on this briefly before. We do find that kids can develop visual fatigue if there aren't a lot of strategies in place for them. So just that's something to really consider. It might be that at the start of the day, the child can read a certain size font, but by the end of the day, that it's too hard for them. And it may come across that they just don't want to do it, or they're disengaged, or you think that they're not able to, but it could be that they're just fatigued because the font wasn't the right size to begin with. So, and that translates to a lot of different activities as well. So it's just something to really keep in mind. Reducing glare. So you can see here today we've got the big curtain across here to reduce the glare coming into the room. It's the same when we think about the environments for kids with low vision as well. So we work with kids on things that they can do themselves or the tasks that they're doing, but we also look at the environment. So for Karen going into schools with kids, it might be recommending putting up curtains. I've done that in a home with a child. We just put up a black curtain across a window just to make that environment easier for them to be able to see and reduce the glare in the room. Stepping back, so this sort of goes on from the hands-on learning, is stepping back and let the child attempt things, and if they attempt and it doesn't go the way you think it's going to go, or that is not successful, then just helping them to achieve success, but knowing that you can also step back. And that's where we try to come in as well. In teaching, we work not only with the children but with families to help guide that learning so that the parent can take a step back, because there's kids that I've seen who are high school age and mum's still doing everything for them. So the child is very, very capable of doing these things. It's just that mum found it easier. So it's just going and helping mum realise that he will be able to do this thing. We just need to take a little bit of a step back. So we come in and work with mum and the child and figure out the right challenge for the child, so that mum can step back and assist, and then eventually step right back and the child can do the task themselves. So that's everything that we've got on our slides today. Did anyone have any questions for Karen or I?
I've got a question. We've had fantastic success with our OT, Vision Australia, etc. I'm just mindful, like my daughter's only sub 2 at the moment, but screens, we have a lot of them in our house, you know, and we have quite a small sort of lounge room, so on and so forth. And in between my partner's phone, my phone, an iPad over there, and a TV going there, she can sort of get access to a lot of that sort of stuff, and they may or may not be all going at the time, but it seems like they almost distract from the other sort of stuff that we're trying to do. So I just noted with the glare point there, is that a factor with that now as well? Like, should I be sort of limiting the number of large screens?
I think it's a real modern day parenting issue, isn't it? Like screens, and we teach kids a lot of assistive technology.
Yeah.
But they use their gadgets as screen readers, as digital magnifiers, they dictate what have you. So in due course, that will be a really useful tool for them. So I do, when I start showing kids how to just, or we start tweaking with the accessibility features on these devices and stuff, I do say to the parents, look, I'm really sorry about this because I'm opening a Pandora's box for you. Welcome to all this, slippery slope that it is. So it is house rules in terms of what you're comfortable with using. People have learned how to do all this cool stuff without gadgets in the past. So you can take a very low-tech viewpoint on that if that's what works for your family. But being mindful that these devices are very cool, and with the AI stuff that they will be, when they come to school, I'm working with kids with iPads. Kids who are blind can operate iPads. There's screen reading technology on that stuff and they use them all the time. So it will be a tool that she will use to access her world, but she's going to learn all the cool stuff as well in a low-tech view. So I haven't answered your question. I've just said she will need to use it, but the balance, it's finding the balance.
Particularly well. I mean, I haven't contemplated it either yet.
And all the research is still coming out in
really
terms
evident that, there's a lot of...
Yeah, and we all know our kids spend too much time on gadgets, like even without vision impairment. So, if you can find the beautiful balance, let us know.
Oh, just because we've got a small lounge room, by the time TV there, and I might be on my phone in the corner.
And the stuff's cool. It's cool and it's engaging. That's why we struggle to get our kids off it. But for our kids with low vision, we do have schools that go. We have a no phone policy, and for our kids with low vision and blindness, we work around that, and so they need this as a digital magnifier. So for a child with low vision, they can't see what's on the board. They'll use their iPad to take a photo of it. Then they can sit back at their desk, so they're sitting back with their mates more inclusively, and Zoom.
Oh, of course. Yeah.
So there are gadgets that will be used functionally for a young child with low vision into the future. But how we let them play with it from a fun point of view. And for kids some of them, dictation's fantastic for kids that are slow typers. That's going to be a way of them smashing out the content and then they can go back and edit it. Screen reading is fantastic. When you've got kids with visual fatigue, and especially if they go into high school, they've got to read stuff. The workarounds are get into audio books or get the screen readers happening. So if you can't physically read the text, you can at least then have it read to you, because we know our kids with low vision, it's got nothing to do with how bright they are or what their reading skills are like. They're often slower readers because you can't skim read the same. So they use screen readers because that's an easier way to listen to the text as opposed to trying to smash it out and read it. And the importance of being able to use the screen readers and then be good note takers so that they're not having to reread chunks of content because it's too slow. And if you're under the pump, you've got to get stuff done at school, you've got to do it quick. So they have to have all these prerequisite skills as little people to then have it in their toolkit for when they're older. So they get introduced to tech pretty early, but probably the boring stuff, not the games and cool stuff. It's the more functional stuff. So but the tech is much more mainstream now. Like some of the toys are becoming a bit more accessible, like dictation, the screen readers, all that sort of stuff's on all your devices here now, and I can show you how to use it, how you can pop up the font and what have you. But isn't that fantastic that our kids are able to use these mainstream devices rather than buying very expensive, specialised kit that does your head in trying to operate? Yeah. Thank you.
Okay, so we are just going to break for lunch now. At this point, we're going to stop the live streaming and say kia ora to our New Zealand friends over the ditch. And we will come back at 2 o'clock, so we'll resume and we'll have the beautiful Kelly, who is a patient